Hello everyone, this is Dr. Shiwani Chaturvedy. In this lecture, I will be discussing about peripheral ulcerative keratitis. To begin with, peripheral ulcerative keratitis is an immune-mediated inflammatory destruction of peripheral cornea. It specifically affects the juxtalimbal cornea and classically presents with epithelial defect and underlying stromal lysis. The key pathological event here is a stromal collagen breakdown, which will lead to corneal melting. And if untreated, it can progress to desmetocele formation or even perforation. Now, this slide summarizes the etiology of PUK, which is divided into systemic and ocular causes. On the systemic side, the causes are divided into infectious and non-infectious. Infectious causes include gonococcal infection, tuberculosis, or syphilis. The non-infectious includes mainly autoimmune vasculitic diseases. Most important is rheumatoid arthritis. It is very important to remember that rheumatoid arthritis is the most common systemic association of PUK. Also granulomatosis with polyangiitis, polyarthritis nodosa, SLE, and other collagen vascular diseases. These conditions cause immune complex deposition and vasculitis at the limbus, leading to stromal melting. And on the ocular side, causes are divided into infectious, including bacterial, fungal, viral, or parasitic, and non-infectious, such as Mooren's ulcer, which is idiopathic PUK, or trauma, keratoconjunctivitis sicca, or any eyelid abnormalities. So clinically, whenever we see a PUK, we must determine, is it infectious, is it autoimmune, or is it because of the localized ocular pathology? Because the management differs completely based on the cause. Now, the importance of looking for systemic clues in patients with PUK, since PUK is frequently associated with systemic vasculitis, recognizing the extraocular signs can help us identify the underlying diseases early. For example, saddle nose deformity is suggestive of granulomatosis with polyangiitis or relapsing polychondritis. Nasal or oral mucosal ulcer can be seen in SLE or in Wegener's granulomatosis. The classic butterfly rash is suggestive of SLE. Hypo or hyperpigmentation may be seen in connective tissue disorders. Temporal tenderness and jaw claudication raises suspicion of giant cell arthritis, and subcutaneous nodules are very common in rheumatoid arthritis and systemic vasculitis. And generalized arthritis is seen in most of the vasculitic syndromes. So whenever we diagnose PUK, we must perform a thorough systemic examination because the eye findings may be the first sign of a potentially life-threatening systemic diseases. So coming to pathogenesis, it begins with various etiologies, most commonly autoimmune diseases. Firstly, there is inflammatory reaction at the corneal periphery, which is significant because the limbal area is rich in blood vessels and immune cells. Next, there is immune complex deposition, which occurs at the limbal vessels, leading to complement activation. This triggers immune-mediated vasculitis, causing damage to the vessel wall and increased vascular permeability. As the permeability increases, inflammatory mediators leak into the surrounding tissue, and complement fragments like C3a and C5a act as a chemotactic factors, attracting neutrophils. These neutrophils releases collagenolytic and proteolytic enzymes, including MMPs. And also local corneal cells produces MMPs, amplifying the tissue damage. The final result is stromal destruction, leading to thinning and possible perforation. So PUK is essentially an immune-mediated vasculitis leading to enzymatic corneal melting. Now, why PUK specifically affects the peripheral cornea? Firstly, because the limbal region is highly vascularized, unlike the central cornea. These limbal capillaries contain immunocompetent cells such as macrophages, lymphocytes, and plasma cells. Second, in patients with collagen vascular diseases, circulating immune complexes tend to deposit at the terminal ends of limbal vessels. This makes the peripheral cornea more vulnerable to immune-mediated damage. Third, the peripheral cornea has higher levels of complement component like C1, nearly 5 times more than the central cornea, which enhances the complement activation. Additionally, limbal vessels extend slightly into the peripheral cornea and provide access to the efferent arm of the immune response. So in summary, the peripheral cornea is immunologically active and vascularized, making it primary site for immune complex deposition and stromal melting in PUK. Patient usually presents with the hot angry eye with significant pain and redness as the primary complaints, often accompanied by photophobia and blurred vision. On examination, there is peripheral crescent-shaped ulceration within 2 mm of the limbus with superimposed epithelial defect and underlying stromal thinning and overhanging edges of the infiltrates. Now the bottom image here shows the fluorescent staining under the cobalt blue light, which vividly highlights the epithelial defect and the extent of tissue loss. Now one thing very important to remember, the hallmark finding in PUK is crescent-shaped peripheral corneal thinning with associated ulceration. Now PUK can present with varying degree of severity and underlying associations. Now in the first image, the PUK is not associated with involvement of sclera, focusing primarily on the corneal periphery. In the second image, it highlights the typical starting point, that is at the junction of cornea and sclera. In the third image, there is a patient of rheumatoid arthritis where the corneal ulceration has progressed close to the center of the eye, which can significantly affect the vision. In the fourth image, PUK is presenting with the scleral involvement, a more extensive presentation often seen in patients with Wegener's granulomatosis. Moving to the management, starting with the diagnostic workup of PUK, I have divided it into 4 parts: laboratory test, imaging studies, microbiological testing, and ocular investigations. So in lab tests, we start with a CBC, ESR, and renal function test to screen for general inflammation and systemic health. Now, since PUK is often a manifestation of autoimmune diseases, we must look for rheumatoid factor and ANA, which is highly positive in rheumatoid arthritis, and SLE. Now, C ANCA to screen for Wegener's granulomatosis, ACE to check for sarcoidosis, HbA antigen to rule out polyarthritis nodosa, where it is present in around 40% of the cases. In microbiology, we must perform routine scraping and cultures of the ulcers in all cases to rule out infectious causes alongside the possible conjunctival biopsy to see for vasculitis and inflammatory cells. Now in imaging, a chest X-ray is vital to look for hilar lymphadenopathy or lung involvement, which is indicative of sarcoidosis or tuberculosis. In ocular investigations, we use ASOCT scan to precisely measure the depth of corneal thinning. Also corneal topography, which allow us to assess the overall irregularities and extent of peripheral damage caused by the ulceration and thinning. This table highlights the antibodies specific to the autoimmune conditions, their sensitivity and specificity. Now coming to the treatment part, our management strategy for PUK is multifaceted, aiming to address both the structural damage of the eye and the underlying biological triggers. The first priority is to restore the epithelial integrity and halt the stromal lysis to prevent the perforation. Also, we must prevent secondary infections as the compromised cornea is highly vulnerable to opportunistic pathogens. And to aid in healing and patient comfort, we focus on improving the ocular surface lubrication. And finally, because PUK is often an ocular manifestation of a large issue, so we must suppress immune-mediated inflammation through targeted therapy. Starting with the topical therapy, we start antimicrobials immediately if the infection is suspected, and once the infection is ruled out, topical corticosteroids like prednisolone acetate 1% is the mainstay, which is used 4 to 6 times started, and once the inflammation is settled down, it is tapered down. And we also use collagenase inhibitors like medroxyprogesterone or N-acetylcysteine to prevent the tissue melting. And for support, constant preservative-free lubricants can be used. Also, prophylactic antibiotics are essential for surface healing and to avoid any secondary infection. Now coming to the systemic therapy, high-dose oral steroids are used as a faster acting bridge while waiting for the long-term immunosuppression to kick in. And systemic collagen inhibitors like oral tetracycline or doxycycline are prescribed for at least a month to inhibit the enzyme driven tissue breakdown. And the most important, immunosuppressive therapy, cyclophosphamide is usually considered a drug of choice for PUK associated with connective tissue disorders. Also, methotrexate is a preferred long term option because of less toxicity, usually given at a dose of 10 to 25 milligrams per week. And cyclosporin is reserved for recalcitrant cases with careful renal monitoring. Also, there are TNF alpha inhibitors which can be used for severe systemic involvement, and long term maintenance is often needed to prevent the recurrence, and collaboration with a rheumatologist is non negotiable for managing the underlying systemic diseases. Now, coming to surgical management, immediate structural reinforcement includes tissue adhesives, like for smaller perforation less than 2 mm or areas of extreme thinning that are about to perforate. We can use cyanoacrylate glue. This acts as a temporary plug to stabilize the eye. Also, amniotic membrane transplant can be applied after keratectomy or conjunctival resection. The conjunctival resection helps in physically removing the inflammatory cells from the site, and the AMG provides a basement membrane for healing. When the damage is too extensive for glue alone, we move to tectonic procedures to maintain the integrity of the glow. Depending on the size and location of the defect, this may involve lamellar keratoplasty, penetrating full thickness keratoplasty, or patch grafts as seen in the bottom image, which are stitched directly over the thinned peripheral area. While these surgeries saves the eye structure, the primary goal here is tectonic stability rather than immediate visual acuity, as peripheral grafting often induces significant astigmatism. Now, coming to the complications, PUK can lead to permanent structural changes, including corneal scarring, neovascularization, and high amount of irregular astigmatism. The most severe risks are progressive corneal thinning and perforation, which can lead to irreversible vision loss if not managed aggressively. And for follow up, continued long term follow up is mandatory even after the initial ulcer appears to have resolved, because relapses are very common. And many patients will require prolonged systemic steroids or chemotherapeutic medications to keep the underlying systemic disease in check, even when the eye itself appears quiet. Our goal here is not just immediate healing but sustained remission through a combination of local ocular care and systemic immunosuppression. Now, highlighting the conditions that can mimic peripheral ulcerative keratitis, to accurately diagnose, we must differentiate it from the other peripheral corneal conditions, which generally fall into three categories: inflammatory, degenerative, and neoplastic. Mooren's ulcer, it is a primary inflammatory differential. Unlike PUK, Mooren ulcer is typically idiopathic and is not associated with any underlying systemic autoimmune conditions. Now, there are some degenerative conditions often present with thinning but generally lack the acute angry inflammation seen in PUK. First one is Terence marginal degeneration, which is characterized by painless, slowly progressive thinning associated with vascularization and lipid deposition. Now, senile furrow degeneration, a benign thinning seen in elderly, typically located in the lucid interval between the limbus and the arcus senilis. Pellucid marginal degeneration, while it involves thinning, it is usually inferior and leads to higher amount of irregular astigmatism rather than active ulceration. Now, neoplastic conditions like ocular surface squamous neoplasia, it is crucial to rule out malignancy, and as OSSN can sometimes present at the limbus and may mimic a chronic inflammatory process. Lastly, one of our most important clinical tasks is to differentiate between PUK and Mooren's. So, Mooren ulcer is fundamentally a diagnosis of exclusion. We only arrive at the diagnosis after a comprehensive systemic workup for the autoimmune diseases, which returns negative. Also, while both involves peripheral thinning, Mooren often presents with characteristic undermined leading edge. And both conditions involve severe pain, but in Mooren's, the pain is often described as excruciating. and out of proportion to the clinical signs. And this is a vital clinical clue that Mooren ulcers typically involves only the cornea and spares the sclera. As you can see in the image, PUK in the right frequently presents with associated scleritis, while in the left, Mooren's shows a clear sclera despite of severe corneal thinning. Now, to conclude, peripheral ulcerative keratitis is more than just a corneal condition. It is often a sentinel sign for life-threatening systemic autoimmune diseases. Thank you.